Last term, there were a couple people who thought the exam stayed open through Saturday or Sunday, and they missed the exam and they were not allowed to take it. So please know that the exam opens midnight Thursday and will close at 11:59 p.m. on Thursday. And each exam will be that way. I've already gotten an email. I'm actually working on grades this evening. I've had some, unfortunately, technical difficulties, but I am able to post grades. So I'm working on that this evening when we get offline. Looks like about 18 people are here. And I guess I'll ask what questions, if any, do you have? The format of the exam, they are all proctored exams. There are 40 questions. You have 60 minutes to take the exam. They're all multiple choice. This first exam will cover weeks 1, 2, and this week as well, week 3. Please have, when you get ready to start the exam, before you start, please have technical support's phone number with you, next to you, by you, just in case there's any technical difficulty. Excuse me, you can quickly reach out to technical support if needed. So I really highly encourage that. The exams are closed book exams, closed note exams, so no books and no notes. Proctor, and they really do review the videos from the proctoring. Any questions about that? Any questions about the exam? 40 points, 40 questions, 60 minutes to take it. Opens Thursday and closes Thursday. Opens midnight Thursday, closes 11:59 p.m. Thursday, and I believe that's Mountain Time. Any questions about the material for weeks 1, 2, and 3? You should be able to open from you clicking on the testing link, but you also should have had some type of training for the proctoring. I'm looking at the question about the drug names. I'm not sure if you see your scores upon exit or not. I believe you do. I believe you do see your scores upon exit because they are already automatically recorded. The question about knowing generic, let me just look and see. Yeah, it looks like generic and brand name would be on the exam. Generic and brand will be on the exam. Try to go back up. For some reason I can only, let me see if I can scoot up and see if I missed anything. Okay, I don't think I've missed any questions. Are there any other questions? And looking at some of the questions, they do give brand and generic names on the exam. Any questions? 20 folks online. Okay, so if there are no other questions, I'll just start going through some concepts, which this will generally be the format. But I will mention, I'm not sure if you all listened in on our meeting last Monday, and that was more so to kind of introduce the course and answer any questions. I did mention that evening, probably later on towards the weekend or early end of this week, I'll be soliciting your input for group assignments. I do allow you to choose your group members if you would like to do that. many students that don't have a preference. But I will be sending out an email to the entire class. I know some of you have already emailed me, but generally I don't even look at those emails until I solicit the information, because I have all that stuff in one spot in my email. So I will send out an email soliciting your input. Within that email, if you are requesting certain group members within the course, the email should be one email from your group, and everyone should be included on that email. Because I have had students before, they've been requested in other groups, and they didn't know they were requested here, or they didn't know they were requested there, and it was confusing. So the only way a group will be approved is if everyone is on that email, which lets me know that everyone is aware that they're being requested to be in a group, and everyone approves to being in that group. If you don't have a preference, either way, no matter what, I'll ask you to send me your, what do you call it, your what is it called, where you live, whether you live in Eastern time or Mountain time or Central time or what have you. Because if you don't have preferences, and I always try to group you according to your time zones. That's what I'm thinking of. Thank you. Time zones. I try to group you. Many students don't have preferences, and with that, I just try to group according to time zones. So be looking for that email coming out later this week. I believe your first group work starts in week 5. So I want to have all the groups hopefully assigned by mid-week 4. All right, so I'm going to review some concepts. Much of what we talked about in week 1 had to do with your state board and being familiar with your state board, and being familiar with different practice laws in your state. So it's important to know what organization or body regulates prescriptive authority for nurse practitioners, and you should know that after that exercise. And generally for these reviews, I just throw concepts out. I may or may not ask you for your input or for answers, but this is mainly concepts that will help you to finalize your prep for the exam. The study guides are really a great foundational tool for preparing for the exam, so I advise you to really put some time into the study guides, to use the study guides to study. And as thorough as you are on the study guides, I'm looking to see if they're completed. But the more thorough you are and the more comfortable you are with the information from the study guides, I think the better you'll do on the exams, because they do help you prepare for the exam. So I would definitely put some work into it. But really, I'm looking to see that it's been completed and submitted, because it's really only, I believe, 1 point. But it will benefit you in the long run to do the study guides, and realize that a lot of the information may come from your text, but you may have to find it in other resources like Up to Date, which is a free, we talked about that last Monday, a free resource to Maryville students. Okay, so getting back to, hopefully I'm not missing anyone's questions. This unit, I think in these 3 weeks, talked about adverse drug reactions and realizing populations that are most at risk. In general, we worry about our elderly and our babies when thinking about that. But it's also important to know why are our elderly more at risk, or why are our babies more at risk for adverse drug reactions, and why they are at higher risk. Anyone can have an adverse drug reaction, but there are the elderly, which, they have other comorbidities a lot of times. They have diminished renal function, sometimes diminished hepatic function. They have other medications that are interacting. All these things can definitely play into adverse drug reactions. So that's an important consideration when prescribing for adults. You should know the prescribing process, and what I'm grading this evening are your prescriptions that you had to do for week 1, and you had to answer 3 questions regarding prescription writing. So all of those go into the prescribing process. If you were to say you needed to dispense an over-the-counter liquid or even a prescription liquid to parents, what is an important counseling point regarding how the parent should administer a liquid or a suspension to their child? And basically, that's relaying the use of an accurate measuring device. So, when you are administering medications, and I'll use warfarin for an example, which is an anticoagulant. Can someone tell me, and this may or may not have been in this unit, but the overall topic should have been covered in these units. What's the main problem with warfarin, the anticoagulant warfarin? What's a major problem with warfarin? If anyone can type that. Bleeding, drug interactions. Yeah, bleeding, absolutely. Drug interactions. And the drug interactions are because of that CYP family, super family of enzymes. Drug interactions, but also remember food interactions with warfarin. But I'm more so talking about drug interactions, and because of medications that are metabolized through the cytochrome P family of enzymes. So you know that if you are prescribing a medication that is metabolized, say by CYP 2D6 or 3A4 or P450, you should know how to counsel patients regarding the administration of the medication. No, you're not expected to know specific CYPs, but you are expected to know the significance of why you need to be aware of what CYPs are as it relates to patient education. There's a medication that is metabolized via cytochrome P superfamily of enzymes, and you should know how to counsel that patient. So it's more so that than knowing specific CYPs. So drug-to-drug interactions are going to be discussed. Also, knowing definitions for things such as what steady state means. How do you define steady state? Knowing what the BBB is. What's the BBB? Anyone know? Blood-brain barrier, yes. Knowing what the BBB is, also the fetal brain placenta, being aware of what that is. And when you think about those things, you can think about pharmacokinetics and distribution and barriers to distribution as it relates to the blood-brain barrier or the fetal brain placenta. When considering pharmacokinetics, and we know pharmacokinetics, the acronym ADME, ADME, which is absorption, distribution, metabolism, and elimination or excretion. When considering the intravenous route of delivery for medications and how distribution is affected by the intravenous route, being aware of that as it relates to maybe the oral route. I mention a couple of antibiotics, let's say I mentioned gentamicin and vancomycin, what do these two medications have in common? Gentamicin and vancomycin, other than we know that they're antibiotics. But what else do they have in common? Peaks and troughs are needed. Not only that, even more so, but peaks and troughs, that is the point. But other things they have in common are the possibility of nephrotoxicity. So renal monitoring is important, as well as ototoxicity. But as far as this unit goes, realizing the rationale for drawing peaks and troughs. Realizing the rationale for drawing peaks and troughs. I think in real world practice, practitioners really concentrate more at troughs than at peaks, because troughs are more closely linked to toxicity than peaks are. But there are some providers that look at both peaks and troughs, because you want your peak to get to a certain level so that you can ensure that the medication is efficacious. So just knowing the rationale for drawing peaks and troughs of certain medications. And vancomycin and the aminoglycosides are examples of that. If you were to look at or think about the drug concentration curve, you should be able to look at that curve and tell or know what point of that curve indicates that the drug has reached its therapeutic effect. You should know what point on that curve a drug has reached its therapeutic effect when you look at a drug concentration curve. Know why certain medications require a loading dose. If you were to think of, give me an example of an antibiotic, a very commonly prescribed antibiotic that requires a loading dose in most cases, what would you say? Azithromycin, the Z-Pak, yes, because you take 2 tablets on day 1, generally 2 of the 250 milligram tablets, and then 1 daily for 4 days. So why is that loading dose important? Knowing that. Knowing what a half-life is and why that's important. What is first pass effect? What is the first pass effect? It is the bioavailability. Yes, it's more so metabolism of the drug through the liver and the significance of the first pass effect and what that means. When you talk about albumin and protein binding and bound drugs and free drugs, you think of a patient that has hypoalbuminemia. What considerations do you have to take for patients that have hypoalbuminemia? That is important. Knowing the different allergic reaction types and which one signifies anaphylactic shock, that's important. Define what a half-life is. When you have certain, and this is more so, again, pharmacokinetics and drug distribution, you have different formulations of medications. So if you say you have an oral medication, and it comes in a regular release formulation. It comes in a sustained release or controlled release formulation. It comes in a liquid. It comes in this and comes in that. So it's important to know how different formulations can be manipulated. For instance, if it is not a coated tablet, but a tablet, and the tablet is scored, meaning that there's a line down the middle, then that tablet can be broken in half and given that way. But there are certain things that you can do and you can't do to control release or sustain release dosing formulations. So it's important to know you can't crush those. You can't crush those type formulations, and why it's important not to. And it is tied to toxic effects if you manipulate the dosing formulation. Knowing what is off-label prescribing and when and why is that used, what that means. When talking about the medication class, this is antihypertensive class, also used in the treatment of BPH. What class comes to mind? Antihypertensive class of drugs also used in the treatment of BPH. What type of drug is that? Nope, not a beta blocker. Beta blockers are usually for heart failure, hypertension, AFib, that kind of thing. Definitely an alpha blocker. Alpha blocker, not an alpha agonist. An alpha antagonist. An alpha agonist would be clonidine, an alpha 2 agonist. I'm talking about an alpha 1 blocker. I call those the OSIN drugs because they all end in OSIN. The alpha 1 agonist, terazosin, doxazosin, tamsulosin, all of those end in OSIN. So I call those the OSIN drugs. They're alpha blockers. They're used in treatment of BPH and hypertension. But what is a problem with alpha 1 blockers? And it's not an agonist, it's an antagonist, alpha 1 antagonist. What is a problem with alpha 1 antagonists that patients need to be aware of? And providers. Orthostatic hypotension is orthostatic hypotension, also sometimes called the first dose effect. And it is prudent to start alpha blockers as a bedtime dose in order to avoid the patient to avoid that orthostatic hypotension. Beta blockers are ones that you should not stop abruptly. They should be tapered, started low and go up slow, as well as tapered down and not discontinued abruptly, because beta blockers can actually exacerbate heart failure and other cardiac conditions. So that's important. If you were to consider, so we talked about alpha 1 blockers. We mentioned briefly alpha 2 agonists, which are centrally acting medications used for hypertension as well as other conditions. What if you were to have a patient, let's say a medication, propranolol? What is propranolol? It is a beta blocker. What type of beta blocker is it? Non-selective beta blocker. What does that mean? What does non-selective mean? Works on all beta receptors. So beta 1 and beta 2. Which demographic patient would you be cautious with a beta blocker. It's not an alpha 1 and beta 1, beta 2. Propranolol is not. Carbidolol and labetalol are alpha beta blockers. But I'm just asking about propranolol. Your asthmatic patients, so your pulmonary patients as well as your diabetic patients. Why diabetic patients? Why should diabetics be mass symptoms of what? Hypoglycemia, absolutely. Symptoms of hypoglycemia, i.e. tremors. And some beta blockers are used specifically to treat tremors. So those things that look like hypoglycemia can be masked by beta blockers, as well as your pulmonary patients can be problematic. Why is that? Can cause bronchospasm because of beta 2 affecting the lungs. Beta 2 also affects glycogenolysis. So these are other reasons why pulmonary patients and your diabetic patients can have problems. I call your beta blockers your OLOL drugs. They all end in that OLOL. Propranolol is non-selective. Medications like metoprolol and bisoprolol and atenolol are cardioselective. What does cardioselective mean? Beta 1 agonists. And then medications like carbidolol and labetalol are alpha beta blockers, which means they block alpha 1, beta 1, and beta 2. So they're non-selective beta blockers plus an alpha 1 blocker. So would orthostatic hypotension be a problem with alpha beta blockers as well? Could be. Could be. And you also have to think about medications like the alpha beta blockers, carbidolol, and the cardioselective beta blockers. If you push the doses on those too high, you can lose selectivity of those medications. So even though technically metoprolol does not antagonize beta 2, if you increase the doses on those beyond normal dosing, you could lose that cardioselectivity. So you still should really use beta blockers, whether they're cardioselective or non-selective, but especially non-selective, but use them with caution in your pulmonary patients. Let's see. Knowing what cholinergic activity is, knowing what anticholinergic activity, how it affects, say, cholinergic activity might affect the stomach. Now, we talked about, someone mentioned rebound, I think tachycardia, with your alpha 2 agonists, which are known as central acting alpha 2 agonists, like clonidine. These are also medications that you should not stop abruptly because of the potential for rebound hypertension. When you're thinking about alpha beta agonists and how they work, you think about vasodilation. You think about vasodilation with your alpha beta antagonists. You should also be familiar with the beta and alpha receptors and what they do. And I've already mentioned that beta 2 receptors can cause liver glycogenolysis as well as gluconeogenesis, which is why beta 2 can affect your diabetic patients. Knowing what alpha 1 does, knowing what alpha 2 does, beta 1 and beta 2. Advantages of prescribing certain dosage forms, i.e. like sublingual medications. While you would prescribe a sublingual medication, the advantage it may have over oral meds. See if there's anything else. What questions do you all have? We've done 30 minutes of solid questions. What questions do you have? So again, when we meet for I'll call it our little chats prior to your exam, it's generally for me to kind of throw out some concepts that you should be kind of not solely focusing on, but there are certainly things that should help round out and finalize your preparation for your exams. But what questions do you have? Any questions out there? I'm not seeing any. I don't know if hopefully I'm not overlooking any. Any questions about anything that I've mentioned? The exam? No particular section that's more relevant as far as your reading or test material. No, that it's all relevant. It's a therapeutic curve in the book. I don't know. When you're talking about pharmacokinetics and that, I think you're talking about the dosing response curve. That should be probably in the foundational part with pharmacokinetics. That should all be with the information regarding half-life and peak and onset of action. All that should be in the same area. Okay. Other questions? That's what I mentioned, the drug concentration curve, drug response curve. That's all. Really the same thing. Yep. Any other questions? Any of the concepts that I mentioned as well? If not, I don't have anything else to pass. I think, there's a question. Did they ask questions in terms of alpha 1 or by drug name? Or look, it's going to be a little of both. As far as alpha 1, alpha 2, beta 1, beta 2, you should be familiar with those receptors and what those receptors do and how they are affected. But you also may see just like you might see, say, alpha 1 blocker or alpha 1 antagonist. And it will give you an example of drug name as well, generic and brand. So both, a little of both. But the receptors, that's really more so like a very small part of autonomic pharmacology. So it's really making sure you understand that, basics of that. Okay, you're welcome. Any other questions? How familiar do we have to be with non-selective or selective drug names? Yeah, there could be definitely a question with a drug name and needing to know which class it is. But generally, just kind of reviewing. The question might ask you specifically, let's say about alpha-1 blockade, but not give you a drug name. Generally, it looks like if drug names are used, then they give you the brand and generic. Any assignment should be in APA format except your study guide questions, meaning there should be a title page, answer the questions, and then your resources should be listed. I don't think there'll be patient scenarios on this particular test. There might be a generic patient given, like a 62-year-old man, and how might this medication affect an elderly person versus a younger person, that kind of thing. But not true like case studies, no. Okay, you're welcome. Anything else? Any assignments should be where you are citing your resources. So even if you're making up questions, you have to have used resources for those questions. So when I say APA, I'm not talking about, strict APA block form, blah, blah, blah. I mean, you need to be citing your resources. Okay, you're welcome. And this is recorded, so as soon as the recording is ready, I will get it posted. Generally, it may not be tonight, probably in the morning before it'll be downloaded for me to post. Any other questions? And again, please have just a reminder, technical support's number in front of you when you get ready to test, so that if there's anything that goes wrong technically, you can easily get in touch with them without having to search all over the place and looking suspicious to the proctoring, that you have that number right there with you. All right, if there's nothing else, I'm going to end the meeting. And again, please email me if you have any questions. How would that work if something technically goes wrong? They will see us using our phone. I mean, if something technically goes wrong, then I would probably state I'm having technical difficulty. I have technical support's number here, and I'm going to call. Because it will be reviewed. So if there's something that's going on with your computer screen, I would just state it. Having technical difficulty. And a lot of students, if they think that something might be flagged, they'll send me an email so that I can forward it on to the proctoring folks, so that when they review it, if there's anything that kind of looks off, and they have that documentation there, because some things do happen, and there's an explanation generally for 9 times out of 10 things that can happen. So if you think there's something that may look, I guess, suspicious, for lack of any better word to call it, then just please send me an email of what happened, and I can forward that on to our lead admin folks that look at those, that look at the proctoring. It's just easier if you have the number right there with you. It doesn't look like you're searching through stuff to find it. It just looks a better look. I have no idea. It just depends. I've had, every scenario is different. I've had students that could not get into the test. They had to take it at a later time, but it just depends. It doesn't happen often, but I just want you to be prepared if it does happen, so you're not looking as if you're, using resources that you shouldn't be using. You're welcome. Yep, I did say that. hmm Any assignments, you should be citing your resources. So that's what I mean by APA. You're citing your resources, even if you're writing questions. You don't have to use page numbers for answers. Okay. Anything outside of your study guides should be submitted that way. Unless it does, unless this assignment specifically says no to that. All right. See if anything else comes up. Not there. If something comes up, we do have a couple days, 2 or 3 days before exam time. So please feel free to email me. If it's a question you have, it's probably a question other folks have, and I'll share the information, not your identity, but your information. If it's a question I feel like everyone would benefit from. All right. Thank you guys. Have a good night. Thank you for stopping in. You're welcome. You're welcome. Everyone have a good evening. And look forward to the posting, the uploading of the video or the recording as well.